Hi everyone. I'm going to talk a little bit about survival analysis with my extremely poor quality video. So I hope that this is helpful. You can follow along with your own slides and just use the visual here to kind of let you know where I'm at. I apologize for the very poor quality of this. I've had some technical difficulties with my phone as my video recorder. Anyways, neither here nor there. Let's just talk about survival analysis. Whew. So, some examples of time to event on the first slide. The reference there is an FDA document that talks about requirements for endpoints in looking at oncology drugs. So some of the endpoints that we're required to look at, the gold standard being overall survival or time to death, time to disease progression, progression-free survival, which includes the time to death or progression, whichever comes first. Disease-free survival is also used in cancers where the tumors can be removed surgically and the patient would be declared disease-free, and then they measure the time for disease recurrence. It's important to remember for any time that we're looking at progression as an outcome, that is a function of the CT scan interval. So patients are typically scanned every 8 weeks in an oncology trial. And so with a PFS endpoint, a patient could die before there's evidence of progression. So time to progression is, it's not as accepted as PFS by regulators because it is a function of the CT scan interval. Other therapeutic areas, there's listed there some other time to endpoints, time to first dose of rescue medication, that might be in an asthma trial, for example, time to death, time to disease recurrence, time to fracture. And this type of analysis is used anytime we're measuring the time to something. So the example there of a battery failure, we would use survival analysis techniques. Okay, so survival analysis is used to compare two treatments when you have a time to event endpoint. So we need to define in the protocol how we're measuring time to the event. Typically, the clock starts at randomization, but that does need to be specified in a protocol. And the difficulty or the challenge with survival analysis is that not all of the patients will have the event that you're interested in. So it's not typically feasible to run a clinical trial until all patients have the event, whether that's death or disease progression. So it will typically just be run for a limited period of time. Some patients will have the event you're interested in, and some patients will not. And in some cases, with disease progression, you don't know if the patient will ever have the event. Or maybe they'll have the event after the trial ends. We just don't know that. So patients who are alive and well at the last known contact of a study are said to be censored. So here's a schematic that shows you patients enrolling at different times. So this shows 5 patients enrolling at different times. The patients that are indicated with the white circle at the end are alive and well. These two at the end of the study. This patient here prematurely terminated, maybe due to an adverse event, and all we know is they're alive and well, and the other 2 patients have died at the time point indicated by the red circle. So the open circles are the censored patients. So censoring, the next couple of slides talk about why censoring matters. It's important not to throw data away. The fact that you have patients alive and well on a treatment is meaningful information that you want to make use of in your analysis. So that slide talks about that as well. So there's 2 components to survival analysis. One is that we want to summarize. This is kind of how we started the course. So we want to be able to summarize the time to event data. And then the second component, we want to be able to compare 2 treatments. So we summarize time to event data using a Kaplan-Meier. We compare 2 treatments using log-rank Cox proportional hazard model are 2 examples. There's other ways that it can be done, but those are the 2 we'll talk about in this course. Kaplan-Meier method is based on calculating the probability of a survival at every point in time when an event occurs throughout all of the patients in the study. We can calculate exact survival probabilities However, we can only look at one variable at a time. There's no opportunity to do anything multivariate with a Kaplan-Meier. So the next few slides step through the actual calculations of the Kaplan-Meier probabilities. Here's some data. We have 2 treatment groups. We have whether or not they're censored, so the patients without an event would be censored, and their time in days is given there. You can have a look at that. You wouldn't be tested on how to calculate these product limit estimates, but given our work with probability, it should make some sense to you, because here we're just looking at whether or not the patient had the event. So we have 1 out of 5 gives us 0.2, and so the probability of not having the event then is going to be 0.8. And because these are all different patients, they're independent. So whenever we have independence, we can multiply probabilities. So we're just multiplying to get those product limit estimates, and that's what's plotted in the Kaplan-Meier plot. Kaplan-Meier plot looks like a staircase. Every step down is an event. The censored observations are typically marked on a Kaplan-Meier plot somehow. I've marked them here with a little circle. The nice thing about a Kaplan-Meier is you can read the median right across, right off, and see it's 132 days. It's the median and not the mean that we use to summarize time to event data. Here's an example of, this is capecitabine alone versus capecitabine plus bevacizumab, the Kaplan-Meier plot. You can see that the 2 plots overlap, so it doesn't look like there's any difference between these 2 treatments. This right tail of the Kaplan-Meier plot, we can typically ignore that, because usually there are so few patients left alive by that point in time that even just this one large drop is perhaps just one patient dying. So we say that this right tail is volatile and we don't pay it any attention. I think that's just saying what I just said. And there I'm showing you also how to read the median off, just straight off the 0.5, 50% line. These are just some questions to consider when you're looking at that graph. I think I'm just getting you to think about how the number of patients decreases over time, how you have few patients left here. Is cap plus bevacizumab better than cap alone? Probably not. What was the length of follow-up? You can see that they were following patients for a little over a year. And median, not the mean, is an important part there as well. And the censoring is indicated there with a little vertical tick in this case. Here's another example. This is sorafenib versus placebo. It's a fairly small trial, but you can see clearly here that the Kaplan-Meier plots separate. We can't see it in this video, but if you're looking at your slide, you can see it. And this is looking at progression-free survival. And so you can see that it is delayed for sorafenib patients. So sorafenib patients are benefiting from this treatment. So median, not the mean. We can estimate a probability of timing of the events. Every step is an event. We have to think about censoring. The right tail is volatile and unreliable. And notice that we cannot compare treatment groups for statistical significance using a Kaplan-Meier. There are no p-values or confidence intervals that are calculated from a Kaplan-Meier plot. It's purely descriptive. How can we compare treatments? Well, we can use these log rank or Cox regression. And these are multivariate regression models that follow some different assumptions and incorporate the censoring. So we can account for different covariates when we're applying a log rank or a Cox regression model. The output from a log rank and a Cox is a hazard ratio, and then confidence intervals and p-values. So when I compare treatments, I'm not comparing medians, I'm actually comparing that survival curve. And I'm going to do that using this hazard ratio. We're going to assume that the risk of the event is the same over time. There are statistical methods when you don't make that assumption, but that's the most common case. And then we're going to get a hazard ratio with confidence intervals and p-values in order to be able to compare the treatments. A hazard ratio is a special case of a relative risk, so you can interpret it like you would a relative risk, and we're going to want to look to see whether or not 1 is inside the confidence interval. So the hazard is actually a mathematical function that's the opposite of survival. So if we were looking at an event of death, then a hazard is the function of death, or the probability of staying alive up to a certain point in time. So this is what it looks like statistically. We use the Greek letter lambda to represent the hazards, and we just have the hazards on an active treatment. In this case, it's monoclonal antibody PMAB, which is panitumumab, divided by BSC, stands for best supportive care. And then we can talk about the covariates being adjusted in the regression. So this is just a reminder of how ratios work. Odds ratios, relative risks, hazard ratios. If you looked at logistic regression, we talk about odds ratios there. We want to look at whether or not the ratio is less than or greater than 1. We want to look at whether or not the confidence interval contains 1. All of those same interpretation rules apply to a hazard ratio. Again, the p-values. So here's an example. We have an experimental versus a placebo. The hazard ratio is less than 1.72, but the confidence interval contains 1. So there's no evidence of a difference between the experimental drug and placebo in this case, and the p-value agrees with that at 0.27. So there's just a little algorithm of how you can go about interpreting the hazard ratio. 2 examples at the bottom there. One of experimental versus placebo, where the experimental treatment, sorry, I'm dropping things over here and I thought I'd turn the video off, where the experimental versus placebo, the hazard ratio is less than 1. So if we're looking at overall survival, the experimental treatment definitely benefits the patients. They're living longer, and the confidence interval doesn't contain 1. Experimental versus standard of care, this is greater than 1. So if we were looking at time to death, the standard of care is benefiting the patients. Here's another output from a phase 3 trial of sorafenib again versus placebo. Kaplan-Meier plot, you can see the curves separating, and the hazard ratio is presented on the plot. Remember that the Kaplan-Meier plot is descriptive, and this hazard ratio, confidence interval, and p-value have come from, I think, this slide doesn't tell us, but I think it was a log rank test. Also at the bottom here, they're indicating how many patients are at risk, and you can see by the time you get to even 56 weeks, there's very few patients left alive. And so there's just a summary statement about that. Here's a good example of the significant hazard ratio, 0.54. This is the monoclonal antibody panitumumab versus best supportive care again. Stratified log rank test, very small p-value, so panitumumab definitely is offering a benefit in terms of progression-free survival. However, if you look at their medians, if you read across from the 0.5, they're almost overlapping. I think actually the result here is something like 5 days or 8 days, I don't remember. So it just emphasizes that the log rank test is comparing the treatments based on time, what's happening over time with these patients, and is not comparing medians, or means for that matter. We don't talk about means at all in survival analysis. So it's the hazard ratio and the confidence interval and the p-value that are going to indicate to us whether or not there's a treatment effect, and then looking at the median and the Kaplan-Meier plot is descriptive. And I think this just highlights some stuff. Right, so then that gives you some, just what I was just saying, just some statements, clarification on that. Here's another example, progression-free survival, cetuximab plus best supportive care versus best supportive care alone. Make sure you can read all of the bits and pieces on here. You've got median PFS, confidence intervals around the median, a hazard ratio with the confidence interval, the p-value from the stratified log rank, all of this information telling us that there is a statistically significant difference with adding cetuximab to best supportive care in the progression-free survival, even though, again, the medians overlap. So cetuximab does offer a statistical benefit. So with survival analysis, you need to remember censoring. You need to remember that Kaplan-Meier offers a descriptive summary, and that if we want to compare the treatments, we need to go to a regression type of model. We didn't look at the model, but it's the same idea where you can feed in many covariates in order to see maybe how baseline characteristics, age, type of chemotherapy, all of those covariates might play a role in the overall survival. And that's it. Thanks very much.